Morning, everyone. As the topic for the today's discussion is uveitis, nothing but the inflammation of uveal tissue. So to understand what is the how does the inflammation occurs for the uveal tissue, we should know what is the uveal tissue. So we will get the one brief anatomy about the uveal tissue, and then we will see what is the cause for uveitis, what is the etiologic factors, what are the different syndromes in which this feature is associated, and how to interpret, how to investigate, and how to manage the conditions. So we all will get to know all these things about the topic over the progression of our topic. So first, coming to the uveitis, as the test word indicates the inflammation. So if the inflammation of uveal tissue, so what is uveal tissue? To go for that, first we'll see the normal anatomy of eye. You can see our human eye is mainly consists of three structure: outermost sclera, choroid, the middle vascular cord, and the inner neurosensory cord is retina. And the interior 1/6 part of this sclera, which is clear, it's cornea. And it's further divided into the with the lens in the anterior segment, posterior segment, and the anterior segment is has anterior chamber and posterior chamber. So even this is the choroid, blue. The anterior most part of the choroid continues as the iris. So this is iris. And from this choroid, we get the ciliary body from which the zonules are suspending. So here the ciliary body is there, which secretes the aqueous, and the aqueous gets secreted, and through pupil it goes to the anterior chamber. So combine these three structures: the choroid, ciliary body, and the iris. These all three structures are combinedly called uvea or uveal tissue. So inflammation of these structures are collectively known as uveitis. So based on the anatomical location, the uveitis will be further classified on which structure is affected. So coming to the definition, the uveitis is nothing as I have mentioned, but it's the inflammation of the uveal tract and the adjacent intraocular structures, which will lead to the different signs and symptoms and manifestations, which we will be discussing in the upcoming slides. So the second thing, it's the inflammation of uveal tract. So what does the uveal tract has? Is what is there in the uveal tract? So uveal tract consists of iris, ciliary body, and choroid, which I have shown in the previous slides. So inflammation of all these three or any one of these structures will lead to the part of the uveitis. And based on the involvement of these structures, the uveitis, for the better management and understanding, will be further classified on the types of inflammation or on the type of anatomical location. So, on the type of, depending on the location of inflammation, as I mentioned, the eye has the anterior segment and posterior segment. It will be divided into anterior uveitis, and anterior uveitis further will be including the iritis and iridocyclitis. And if it involves the middle coat of the eye, that is the choroid, if it involves the only intermediate choroid layer, then it will be known as intermediate uveitis. It is the condition is cyclitis. And the third one is when it involves the posterior segment, and it is known as the posterior uveitis, where it will affect either retina. When it affects the retina, the condition will be known as retinitis, or choroid, it will be known as choroiditis, or if it will affecting both the structures, so it will be known as retinochoroiditis or chorioretinitis based on the affection. So now we will see how the etiologic factors, or how, which are all of the conditions this structure will get affected, and how to diagnose and how to manage over the upcoming slides. So after that, this is the based on location of inflammation, but sometimes it will lead to the involvement of the entire eye from the anterior segment to the posterior segment, and in that condition, this condition is referred as panuveitis. So this is a diagrammatic representation where it is affecting only the iris and part of ciliary body, so it is iridocyclitis. When it affects the middle vascular cord, that is the ciliary body, it is known as cyclitis. And it involves the inner coat of the eye, that is the retina as well as vitreous and choroid, so known as posterior uveitis. And whenever it will involve all these three structures, anterior, intermediate, and posterior, collectively it will be called as panuveitis. So I think till now everyone is clear about the anterior, intermediate, posterior, or pan uveitis, and what is uveitis. So coming forward, we'll go in brief for the general etiologic factors which will lead to the occurrence of this condition in the human eye. The commonest condition which is seen in the autoimmune, in most of the 50% cases when there is no excess or any underlying etiology made out, 50% of cases will be affected by autoimmune disorders. Infectious, neoplastic or masquerade syndrome like lymphoma and other blood cancers, or retinoblastoma, or other extraocular symptoms or syndromes also can sometimes lead to the affection of the anterior segment as well as posterior segment and can lead to the development of the uveitis in the human eye. And traumatic or post-operative. So these are the broad classification for the etiology, which we will be discussing in the upcoming slides in the detail. Because the etiology is important to diagnose the cause of the etiology, and the management will further will depend on the type of uveitis. So coming to the normal clinical features, which will the patient will be present in the anterior uveitis. Patient will be having the pain with redness. Patient will get the history of 1 or 2 days with the severe redness and pain with loss of function sometimes, the swelling of the lids, and sometimes the discharge or exudates. And classically, sometimes the patient will give the pain in the early morning and sometimes in the evening also over the upper lid region. That is because of the ciliary spasm. And whenever it will get affected, you can see this is the normal picture of the aqueous humor dynamics, which I have shown that the ciliary body will produce the aqueous humor, and the aqueous humor, this blue line you can see, the aqueous humor will proceed from the posterior chamber behind the iris and will go to the anterior chamber, to which the trabecular meshwork, it will be cleaned up by Slem's canal and it will go to the venous drainage of the eye and further. But in the uveitis, what happens? The ciliary body is affected, so the production of the aqueous can be hindered. It will be either hampered, will go to the underproduction, or sometimes excessive production will start, and that can lead to the further complication, which we will be discussing in the upcoming slides. So this is the further diagrammatic representation for the aqueous production and the movement of the aqueous. So how does it affect the eye? And sometimes it can lead to the low IOP or increased intraocular pressure. That etiology, this diagram will help you to understand how does it happen. Depends on the where the structures have been affected. So the common clinical features when the patient will be presenting to you in examination, you will see the deposition of the keratic precipitate. These are nothing but the exudates, which will be containing through macrophages cells as well as the proteinaceous materials which will be secreted in the anterior chamber in the affecting during the inflammation of the uveal tract. And based on their deposition and their size and their colors, they will further divide it into the different types. So this is the one picture which you can see where the endothelium of the cornea has been shown, the multiple small to medium to large size deposits which you can see over the entire cornea. This is the slit lamp examination in the cross oblique view where you can see the posterior surface of the cornea. Like this is the beam which I made, the anterior surface cornea. This is the endothelial layer where you can see the deposits over the endothelium, the multiple deposits. So, what are these keratic precipitates? Actually, they are the deposits which occurs on the corneal endothelium, which usually composed of the inflammatory cells, that is phagocytic neutrophils, and some of the proteinaceous materials which are oozes out to the cells. And based on their location, their type, their size, they are further divided into the the further types like mutton fat keratic. These are usually seen in the large size KPs, which are usually seen in the granulomatous reactions or granulomatous hydrocyclitis or uveitis. Small and medium sized KPs, they are usually seen in the non-granulomatous conditions. These are the small, fine stellate type of usually they are characteristic of the fuchs uveitis or fuchs heterochromic hydrocyclitis, which is usually seen in the young adults, and they are usually unilateral. In herpetic iritis also. A small size, stellate, fine shaped keratic precipitates will be seen on the uveal tissue. So these are the different types of uveal tissue which will be seen on or which will get deposited on the endothelium. So other than this, then the old KP. The old KPs are actually the same exudative deposits in the endothelium, but these are seen in the heel kind of uveitis. They are not something, there is no activity in that, but they are kind of a fibrosis structure which are already deposited on the cornea. Based on these findings, the thing is, whenever you will see, you will make the diagnosis and you can differentiate what can be the certain etiological factors for this. For example, if you see the small old keratic precipitates where there is no activity, you will understand that the patient has the past episodes of uveitis in his one or both eyes, and now patient is either symptomatic or patient can have the similar attacks in the future. So you can explain to the patient, like the young patient, preferably female, one-eyed, kind of a quiet eye, but you will see the fine stellate size of keratic precipitates over the endothelium. We'll suspect the foremost diagnosis of the Fuchs uveitis. The complications we will be discussing in the upcoming slides will lead to the first certain complication, and maybe patient will be presenting due to those complications. For example, development of the cataract. Sometimes the patient will present to you with the cataract, and when you examine, you will see several fine stellate keratic precipitates are deposited over the endothelium, and then we discuss with the patient and ask the patient if anything has gone or anything has happened. Then patient will explain to you about the conditions, and he will tell, like the previously patient has suffered the symptoms and sign, he will tell of which you will be able to make out about the uveitis feature. So with that, you can make the diagnosis of uveitis, and then if you are planning to cataract surgery, you can plan according to that. So we'll move to the further slides for the upcoming information about our topic. So this is the same picture I have shown you previously. This is the cross section. In oblique view, we are seeing the straight line. See the end. This is the anterior view. This is the posterior view. You can see the anterior view is clear, and the posterior view you can see the multiple dots like deposits of different side, brown, dark brown colors. These are the keratic precipitates. Okay. This is the picture which shows the multiple small, medium sized, and large size keratic precipitates. It's seen like a severe uveitis picture, active infection. They're all around the endothelium is studded with the keratic precipitates, which are exudates composed of the phagocytic or inflammatory cells, which are there to fight with the infectious organisms. So these exudates usually will be get deposited in the lens, the cornea, or sometimes the reactions will be seen in the anterior chamber also. So the reactions will be defined on the basis of presence of cells, flares, and hypopyon. What are these? What are the cells? What are the flare? What is hypopyon? That we'll see in the upcoming slides, and we'll discuss how to grade this, because the cells and flare, they are the important things. When we will grade them, based on that, we'll grade our uveitis also. So we'll move further. Okay. So this is the picture you can see, the slit lamp examination on the oblique view. When we are putting the light, you see the light crosses the anterior chamber. And I think you can see the small dot-like structures are seen here, anterior chamber. And this anterior chamber small dots, they are the cells. Actually, the cells, they are not stable. They will show the Tyndall effect. Like the Brownian movement will be there. So we will make the slit to examine this, the slit of 1 into 1 mm. And we'll pass through the cornea. When this light passes through the anterior chamber, we'll see the Brownian movement. I think all of you know what is the Brownian movement, the Tyndall effect we have seen played in the school. So the same movement will be seen in the anterior chamber. Ideally, there is no reaction is seen in the anterior chamber. When we will examine the normal patient or the patient who doesn't have any complaint, you won't see any cells. In the uveitis patient, you will see the one fine particulate movement, Brownian movement will be seen in the anterior chamber, and those are nothing but the cells. cells. They are the cells which are composed of the proteinases exudates with the inflammatory cells, which are dying inflammatory cells. And when these cells are there, when you will see the one light path will be tracked. You can track the light path. See this path you can see. Here you are seeing dark, but you are seeing this path is going. This path is nothing but a flare. So it's because of reflection of the light from those cells. So when cells are not there, flare won't be there. But it's not hard and fast that cells and flare can't be and should be always together. Flare can be there with anything which is disturbing the normal clearance of the anterior chamber. Like the same way cells, if they are not refractile, you can see the minimal flare or no flare with the cells. Usually whenever cells are there, the reflection will be there, and with the reflection you can see flare and cells are present. So these cells and flare, they give you the clue towards the diagnosis of your uveitis. So I have mentioned these small particulate matters, they are the small things, they are cells, and the reflecting light from this, which is seen all around the light path. You can see here it's dark, but in the light pathway you can see the light is traveling. So this light traveling part is the flare of the flare. So now we further go and we will divide the cells and flare based on their quantity. So when there is no flare, no light path seen, its absence, the grade 0. Plus when faint flare you are seeing, faint light path is you see. Plus when this moderate flare is there, but iris details are visible. 3 when +3 when a flare is marked, is you can see the iris, but the details can't be seen properly, clearly. It's hazy. +4 is the intense flare, fixed fibrinous aqueous. The full anterior chamber is filled with the fibrinous material. You can't see the iris, you can't see any other details. So that is the flare. Oh, sorry. Now we will discuss the cells. As I mentioned the cell, so they are further classified like cells also. The standard Uveitis nomenclature committee has graded this grading and will use that for the classification of the cells and then for the classification of the uveitis. If there are no cells like in the normal vessels, we will mention. Well, 0.5 cells are means when you are seeing per hour per high power field, you'll see 1 to 5 cells in per high power field, then it will be 0.5 plus 1, and you will see 6 to 15 cells in the anterior chamber, plus 2 if 16 to 25 cells in the anterior chamber, and plus 3 if it is more than 26 to 50. Or if it is more than 50, then it is a severe uveitis in its grade 4 plus. So these are the criteria which we will follow to divide the cells in the anterior chamber. And with this, it's divided into the grades. And based on this grading of the cells and flare, this will help us in the grading of the uveitis. So this much I think everyone has understood. Now we'll further move on the upcoming slides. Yeah, this is the one picture which shows the hypopyon. Hypopyon can occur in the multiple conditions like in fungal ulcer or any other corneal ulcer. But same in uveitis, in severe cases of uveitis, when there will be severe exudation. That exudates will be so severe that cells and exudates will get collected in the anterior chamber. And this collection will be known as hypopyon. Hypopyon basically means collection of pus in the anterior chamber. So this is known as hypopyon. This is another picture which is showing the hypopyon, that is a collection of the pus in the anterior chamber. This you can see the well-marked hypopyon in the anterior chamber. So, coming to the finding, then the finding over the iris. So when we see these exudates, as I have mentioned, the keratic precipitates will get accumulated over the endothelium lens, like that. Those pigments or exudates will get deposited over the iris tissue also. Sometimes they will affect the iris and the entire iris tissue will be affected. And in that condition, this iris structure of the curve is known as the muddy iris. Then the iris is totally stuffed with this exudative tissue and not able to mobile. Sometimes these exudates will get deposited over the iris in the particular nodular forms, and those nodules will be deposited, and the nodules will be known as like Koppes nodule and Brusaka's nodules. But depends on their location over the iris, either they are at the pupillary margin or the stromal level. We'll divide them into the will give them the name as the scientist has discovered them. Sometimes because of severe stuffiness of the iris with these exudates, the blood supply of the iris will be hampered and the iris will go into the atrophy, and sometimes the formation of new vessels over the iris will occur, which is known as rubeosis. Yeah, and this is the picture which is showing you the deposition of the iris nodules. See, these are the iris tissues, which are iris nodules, which are deposited over the pupillary margins. Those who are deposited at the pupillary margin, and you see in this picture, these are the iris nodules. They are quite small, I think, but I think you can see they are in the beyond the collarate part. So those are deposited at the pupillary margin of the Koppes nodules, and the other one is the Shaka nodule. This is the iris atrophy. You can see the entire iris tissue has lost its curvature, and the pupillary margin iris reflect like outwarded. So you can see the entire iris tissue has been is the small nodules, and then in between that you can see the whitish discolored iris, the lustreless iris. So this indicates the presence of iris atrophy. This you can see the vessels, like whatever the vessels you will see the cornea. On the conjunctiva, same kind of cornea is avascular. So same kind of these vessels you can see. They are not on the cornea actually. They are in the anterior chamber of the iris. So the development of the new vessels of the iris, this condition is known as rubeosis iritis. This is also one of the complications which can happen in the uveitis patient over the time when it is not properly treated. The previous pictures you have seen, see in these pictures, there is no vessels at the iris. This is not it's not normal iris, it's the iris, that's why the pupil is irregular. But now I have shown this. See the how branching vessels over the iris. So this condition is known as rubeosis. So now moving to the next slides, we'll further see about the division. So as I have mentioned, the exudates will deposit it all over. Like it will get deposited over the endothelium where they are known as keratic precipitate, lens. Just now we saw over the iris like Brusaka's nodules, Koppes nodules, which will get deposited over the periphery of the iris or metastromal iris, and as well as the pupillary margin. Next comes the exudates. What will happen to the pupil? Pupil is an aperture between the iris. So when they will get deposited at the pupillary margin or in the iris, the constriction of iris will be like normal constriction power of the iris will go. The normal mechanism of the pupil, which is we know the round regular reactive to the light, and there is a direct and indirect reflex. So the reflexes of the lights will be absent because the iris tissues are affected and those tissues are not able to constrict or not able to dilate. So what all the conditions you can see in the patient with uveitis. So you can see either the constriction of the pupil. Okay. So why that constriction happens? Because when they were exudates, the exudates will go in the iris as well as on the lens also. So iris will be totally stuffed, and in that the flabby iris will get stuck over the lens. When it get stuck over the lens, see, I will show you. This is the previous pictures I have shown. The ciliary body will secrete the aqueous, and the aqueous will move behind the iris in front of the lens, come to the anterior chamber. The signing is nothing but iridocortical adhesion. This iris got adhered to the lens. You can see this is the iris which has adhered to the lens, and below also. So that happens because the iris is totally affected with the exudates and has lost the ability to contract. So, and the adhesion of the iris with the lens is known as the posterior synechial. Similar way, if sometimes iris get connected to the cornea, which usually is not seen in the uveitis, is seen in the traumatic condition. Whenever something will hit, penetrate the cornea, damage the iris, and when the aqueous will leak out, the iris will move with the aqueous and will get stuck under the cornea. So those are the anterior synechial, which is usually not seen in the uveitis. So if the iris got adhered to the lens, then the pupil will be affected. So it can be either irregular pupil, I'll show you in the upcoming photos, where the pupil at the part of the iris has got stuck to the lens. So the pupil has become irregular because it means when you will dilate, it won't dilate, or wherever the iris tissue is not stuck over the lens, that part will be normal and the stuck part will be affected. So the pupil won't be having the normal regular shape or round shape. And the one is the festoon pupil. This is the condition when you will see after dilating. You see the patient has developed the synechia and you will put the dilating drop in the patient eye. The iris pupil won't be able to dilate properly. This pupil will dilate wherever the normal iris tissue was present, but won't dilate where the synechia was formed. So you can see the haphazard dilatation and the irregular dilatation of the pupil. And that condition is known as in that condition, the pupil is referred as festoon pupil. Coming to the, yeah, this you can see the festoon pupil. When we have put the see, these are the parts. This pigment, this pigmented part, this pigmented part. This is the place where the synechia has formed. It's where the iridolenticular adhesion has occurred. Iris is adhered over the lens, but in between this part, this part, this part is not adhered to the lens. So whenever we will put the dilating of this normal portion of the iris will dilate, but the stuck part, which is the iridolenticular adhesion part, it won't dilate. So people will be irregular. Like you can see the here on the diagram, and it's like ballooning in between the pupil. So this kind of irregular pupil is known as the festoon pupil. I think everyone is clear. If anyone has any doubt, can ask. This is another real photo. You can see the pupil is adhered, the iris is adhered over the lens in various places. So this iris can't dilate, so pupil is not dilating, but this portion is not adhered, this has dilated in between the part. The pupil is irregular total. So festoon pupil, which is seen in the usual severe uveitis or in the old uveitis where the already the iridolenticular adhesion of the posterior synechia has been formed and the pupil is not dilating properly. These are the festoon pupil, and how does it happen? What does that indicate? So like whenever in the any patient, suppose patient has not presented to you during the attack, in the any time while cataract, he has come and you will examine, you will see these kind of conditions. You will understand and you can retrograde, ask the patient if he has ever suffered from the any attack of the uveitis. So based on that, you can make the diagnosis of uveitis, and we can continue the examination, and you can manage the patient accordingly. You can explain him what are the post-op complication can happen or what are the things can affect him in surgery. So he should be aware about the conditions what he's gonna happen, because the post-operative period he gets the infection, he can blame. This is a quite good picture of the posterior segment adhesion, but the adhesions are not permanent. So see this, the pupil is dilated and left the iris pigment over the lens, but this pupil is not dilating here properly. You can see the ballooning in between this festoon pupil, which is quite irregular shape because of the irregular dilatation. It's dilatation of the only the normal part, the synechial part is not able to dilate. So you get this kind of irregular pupil. Again, one more picture showing the festoon pupil where you can see the synechia is formed in multiple places, but the dilatation of the pupil at the normal iris level. You see the multiple pigments are deposited over the lens. And you can see the alteration of the normal reflex of the lens. Means the maybe the lens is getting cataract just because of this complication. So whenever we are managing this kind of patient, we are taking for the cataract surgery, we have to take the extra precautions because the people won't be dilating, iris is totally stuffed. So even we'll release the synechae, there are chances that capsule tear will happen, the tear can go to the posterior capsule, the posterior capsular vent can happen, or if not, not likely, but when we will release the pupil, people won't dilate. The iris will be very flabby. So during the intraoperative period also this iris malhandling will happen and the patient will have the severe post-operative reaction on the intraoperative complications also will happen because of this. So all these things we have to explain the patient and we have to take the extra precaution when we are operating the patients with the cold uveitis or severe uveitis attacks we have been in the past. And, we use the different mechanisms like VHX strings or iris hooks to dilate the pupil in these kind of cases. Similar condition of the western pupil. So the condition as I have mentioned the pupil. So what the pupil size will happen after this synechae formation. So the conditions will be known as occlusal pupillae and one more condition is occlusal pupillae. How will it happen? So the mechanism is the posterior synechae is you have, all I have understood is the ido-lenticular adhesions. So if it is and the ido-lenticular adhesion is 360 degree, that is the ring synechae is formed. So all the 360 degree, the ring synechae 360 degree ido-lenticular adhesion is there. Then the condition, the occlusal pupillae will happen. What will happen? The iris bomb. How will it form? As I have mentioned you, the normal aqueous pathway I showed. When there is ido-lenticular adhesion at all the 360, nowhere the aqueous will be able to move out to the anterior chamber, and it will get collected behind the iris and in front of the lens. So the iris will have the formation of water bags, and they will bump out like a balloon. They are known as the iris bombay. Okay. So this iris bombay, when they will form, they will push the iris and there is a peripheral anterior synechae is formed. So aqueous is not going in the anterior chamber. The anterior chamber shape will distort, it will become funnel shaped. And the pressure behind the iris will work and it will lead to the development of anterior intraocular pressure. Yeah, this is the picture. See, suppose this is the peripheral posterior synechae all around 360 degrees. And here you can see the aqueous will produce from here, it will come to here, but it is not able to go to here. So it will form here and it will start pressing over the iris. Iris will bulge out. Here the picture is not that clear. It will bulge out and will lead to the formation of iris bombay. So when it will bulge here, it will be like bulge, then here bulge, then here bulge. So it will be like balloons bubbling. So the anterior chamber will become funnel shape and it will push the entire iris tissue forward. And as I mentioned, the anterior synechae attachment of iris to the cornea. So this iris will get added to the cornea and the patient will develop formation of anterior synechae. So the iris bombay, it will lead to formation of anterior synechae funnel shape and it will lead to the glaucoma miss. This I have explained that because of this, the aqueous tissue is not able to come here. Whatever aqueous tissue is there, because of this anterior synechae, the trabecular meshwork is trapped and the aqueous is not able to move out from the anterior chamber. So the aqueous, whatever is there in the anterior chamber will remain there and the pressure will rise. So this you can see the picture of occlusal pupilla where there is a 360 degree ring synechae has formed. The picture is classic. So because of this, the fluid is getting collected behind the iris. See, the entire iris appears a bulge out. There's the iris bombay. This is not that classical iris bombay. Otherwise, it will be ballooning in between. So it will be a iris bombay formation because of this bulging. The anterior chamber has become irregularly shallow. It's the funnel shaped. You can say the chamber you will see, and this bulged out iris, it will clog the trabecular meshwork here. Okay. So it will lead to the increase in the pressure. See, this is the classic funnel shape. See, the pupillary margin also obstructed. This iris is totally bulged out. So only depression is there in the pupillary margin. So it has become, see the beam of the light. Otherwise, the beam will be almost straight. just here slide iris after lens, it will be straight. It won't be like this, sloping. As you can see. So presence of these signs, they will indicate that the seclusive pupil has been formed. Usually these things happen in the chronic severe uveitis. The next condition which I have mentioned is other than seclusive pupil is the occlusal pupil. Occlusal pupil, they are irregular blockade of the Seneca formation. They're not the 360-degree, but alternate, you can say the alternate formation of the Seneca at all around the pupillary margin. That will lead to the same condition, the bulging of iris and the iris bombay formation in the peripheral anterior Seneca, which will hinder the drainage of the aqueous from the anterior chamber, and anterior chamber will become funnel shape, the pressure will rise. Yeah, this is the occlusal pupil. You can see mid dilated pupil fixed, the ballooning of the iris, which causes again the slopy edge. This is the balloon, and then the light is passing over the lens straight, and now the funnel shaped AC. So these are the features which indicates that already patient has been affected and has developed the either the recent or the old attacks of the uveitis is already there in the patient. Right. So now with this, I think all of you have understood the mechanism and the physiology and the consequences which can happen with the severe uveitis, the affection of the pupil, and what is the occlusal pupil, what is the seclusive pupil, how does it affect, how does it lead to the raise in the anterior chamber pressure. All those things have been mentioned. To the next slides. And the picture of the occlusal pupil, you can see pupil is constricted and stuck over the lens, and the iris bombay has been formed, and the anterior chamber has been become a funnel shape, irregular, and leading to the formation of anterior peripheral anterior Seneca also, which is causing the raised intraocular pressure. Now the another structure where the exudates get deposit. Exudates will come in the anterior chamber also, which we have already discussed, and then when they have mentioned, they'll get deposited over the lens also, and can cause the cataract. So their particular deposit over the lens, and they can lead to the breadcrumb appearance, and these are the cataract which is formed due to this uveitis. They're kind of the complicated cataract, which are not the natural phenomena due to some complication or either trauma, they have been formed. So these complicated cataracts will be of the particular appearance, either there is the breadcrumb appearance, or the name is given, or the polychromatic luster, or sometimes these exudates will go behind the leak in the capsule, and they'll go and deposit it in the posterior capsule also, posterior subcapsular area also. Posterior subcapsular cataract. The picture of that, when we make the beam, you can see the anterior lens is clear, but the posterior segment, posterior pole of the cataract, is a whitish opacification, attachment of the lens and capsule. Behind the lens and capsule, there is a deposition of white exudates or theorized exudates. They form the posterior subcapsular cataract, and they hinder with the obstacle the normal patient's vision, and patient will come with us with the definition of vision. Will examine and will assess the development of the posterior subcapsular cataract. Representative view, you can see the normal lens. This is Y convex or planar convex. See the anterior pole, this is epithelium, the equator of the lens. Cortex nucleus, and that is the posterior pole. You see this lenticular opacity, these are the exudates which I was showing. They'll come and they'll get deposited of the posterior pole of the lens. And the vision, the light which will pass straightforward, you won't be able to cross this lenticular opacity. And the patient will develop the posterior subcapsular cataract. and then we have to manage that cataract accordingly. It's a good picture of polychromatic luster. You can see the multiple chromatic or different colors structures you can see in the lens. They are not the normal things. There are normal deposition or normal changes in the lens proteins or deposits which get deposited over the lens. And they shines like this. It will end up with the patient's vision. This is one picture which is showing the cyclitic membrane. When there is severe reactions, the exudates will get deposited on the posterior capsule. Can lead to the formation of the membrane. And the membrane is known as the cyclitic membrane. Like this is the anterior picture which you are seeing. This is the diagrammatic representation where you can see the posterior capsule has been affected. The membrane has formed over the posterior capsule. So these are the difficult cases to manage because in this, if you will remove the lens also from the back and you will put, since it is the cyclitic membrane which is behind the posterior capsule, so the patient vision won't improve because anyway you have put the lens, but the opacity is behind the posterior capsule. So ideally, we should remove that cyclitic membrane also. And the management of that is the different, and we will discuss later in the different classes. Okay. So sometimes the vitreous will go into the posterior chamber, a posterior segment also, and the patient will be seeing the cells, floaters, or all these things examination. They will be there in the vitreous cavity. Cells are the same, which was there in the anterior chamber as I mentioned, but they'll go to the vitreous. So you know the vitreous is a jelly-like structure filled in the posterior segment. This is the normal posterior segment where the vitreous is filled. These are the cells which they'll come in the opacities in the vitreous. They are known as the floaters. They are the permanent opacities. Which over the time they can get increased or they can get disappeared also. But whenever the patient will see, it will be seen on a particular field. And wherever the patient will rotate, it will be on the same place or will be slight moving, different from the reflections. See, this is the patient view. The kind of exudates which are there in the posterior segment, patient will be seeing these kind of floating objects, but they will be same. Like patient will move here, there, they will be at same place. There will be slight disturbance, but they will be there. Won't disappear. Like the normal reflections we see in the daylight, they can disappear. As I have mentioned, the uveitis can be pan uveitis, anterior uveitis, intermediate uveitis, or posterior uveitis. So just now we saw the vitreous involvement, that is the posterior uveitis. Means the uveitis features or uveitis pathology has reached to the posterior chamber also. Posterior segment also. So in the posterior segment, it can affect the retina, vitreous, choroid, or all the structures based on the finding. So we saw just now the cells in the vitreous. Now these are the macula. Sometimes when they affect the retina, this can lead to the swelling of the inflammation of the edema of the macula, macular edema, which will lead to the diminution of vision, and lead to the papillitis. In the papillitis, you can see the big structure, the surrounding structure of the region of the disc is highly inflamed. The normal architecture of the disc is lost, and this also causes the diminution of vision. In the severe cases, this case is what severe last stage is quite rare in the kind of uveitis. The patient will go for the thesis bulbi, can have. So these are the signs. Just for the revision purpose, I am showing you the signs symptoms of the anterior and posterior uveitis. So we'll see what is their anterior uveitis. As I have mentioned, what is anterior uveitis? Anterior uveitis is the affection of the anterior part of the uvea, that is iris, and sometimes iris and ciliary body. So iritis and cyclitis, part of cyclitis, iridocyclitis. These things combines anterior uveitis. So what are the symptoms patients will have? Patient will give you the history of severe congestion, that is redness, pain, and diminution of vision. because the exudates will come. The signs will be there, congestion, and due to exudates, if the exudates are deposited over the cornea, there will be KPs. I have already showed you the films, photos, and explain what are the metal fat, fine, distillate, the different types of KPs. And if the exudates goes in the anterior chamber, it will be in the form of cells and flare. And sometimes the exudates get deposited, the base of the cornea are collected, and then it is known as hypopion, that is in the form of pus. And it can affect the iris and pupil also. I have mentioned when it will affect the iris will be muddy iris, stuffed iris, non-reactive pupil, as we have mentioned, the pupillary affection, the different pupillary affection, and the pupillary affection patient will have the different types of the pupils like occlusal pupillae, seclusal pupillae, atrophic pupil, iris atrophy. So these are the things will be seen in the anterior uveitis. So this is the summary of what all the features we have seen. You can draw this in the exam. It will very nicely, it will be combining or mentioning with all the clinical features or signs and symptoms which the patient will have with the uveitis and what all the structures has been affected. So just try to remember it, and this will lead to you good information about the anterior. Now see the continuation of the previous photo, the iris. What will happen to the iris? As I mentioned, either muddy iris or there will be formation of nodules. So what the nodules, Bosaka's nodule, Copious nodules, which I have shown you, will get deposited over the different part of iris, or sometimes the neovascularization of iris will happen. That is the development of the new vessels. And the what the findings you will get in the pupil, either pupil is totally constricted or adhesions have formed. Then the adhesions will be isolated adhesion or particulate impartial adhesion, there will be in particular distance, or there will be signing a all around. So if isolated adhesion, it can lead to the irregular pupil. Means wherever the adhesion is formed, that pupil won't dilate, the remaining normal pupillary part will dilate, and that will lead to the irregular pupil, a festoon pupil. I have showed you if the irregular synechiae are formed all around, that the pupil will be festoons, which will be seen only after dilatation. And if the posterior 360-degree synechiae are formed, then it will lead to the ring synechiae, and that will cause a seclusal pupillae. And seclusal pupillae will lead to the formation of collection of the prosumer in the posterior chamber behind the iris in front of the lens, will lead to the bulging of the iris, and will lead to the formation of iris bombae. When the iris bombays are formed, it will push the iris forward and can lead to the blockade of trabecular mesh due to the formation of the peripheral anterior synechiae, and it will lead to the entrance of the drainage of the normal aqueous from the anterior chamber, and the patient will develop the raised intraocular pressure in the anterior chamber. The same thing conditions come when there's an interrupted synechiae, and the patient will develop the occlusal pupillae. Same thing, the occlusal pupillae will enter the normal flow of the aqueous from the posterior to anterior chamber, and will lead to the formation of iris bombae, which will cause the formation of the peripheral anterior synechiae and development of the raised intraocular feature. So these are the anterior uveitis findings which are seen. Anterior chamber or anterior segment of the eye. The patient affected. So as I mentioned, exudates. All the exudates, where all the exudates get deposited based on the that. So these are the summarized tables. You can remember everything at one place. It will be easy for you to assess also. So the lens, when they get deposited over the lens, they can lead to formation of cataract, and the different appearances which will be seen will be polychromatic luster, which I have shown you in the photo, either posterior subcapsular cataract or blood gum appearance. This is the polychromatic luster. You can see the, I think you can see the different chromas, different colors in the lens, and deposited. So the lens has become cataractous. This is the posterior subcapsular cataract. Okay. I don't have the photos for the in the cyclitic membrane, which I have showed you in the previous slides. This is the cyclitic membrane, which is found behind the posterior capsule. And the lens behind the cyclitic membrane, and when the further in the vitreous and the exudates reach, there will be either cells and the conditions which have shown to you in figure will be present. Totals, I have shown you how they appears and how the patient will tell. When it will involve the posterior segment, the retina is affected, then it can lead to the inflammation of the optic disc or swelling of the papillary region of the optic disc. This is known as papillitis, or development of edema of the macula. This picture of papillitis. You can see the inflammation. And this is the macular edema. You can see the macular area appears dull, FRH absent, and it appears edematous. And last stage, phthisis bulbi, which is seen in the last, if the patient has not been treated or it does not resolve, that can lead to the complete loss of vision, and then the patient will have the blind eye, and over the time the eye will start shrinking and reduce in volume as well as in mass, and the condition is known as phthisis bulbi. So, as I mentioned, the IOP is usually, I have mentioned the causes of the physiology mechanism of the occlusopupillary and seclusopupillary. So you have seen how does it lead to the increase in the intraocular pressure. But is it always necessary that patient with uveitis will have the raised intraocular pressure? Not necessary. The patient can have anything. It can have the reduced intraocular pressure also. How the pressure will increase? That I have already shown you in the previous slide. So decrease is whenever the uveitis affect the middle layer, that the intermediate uveitis, like cyclitis or panuveitis, whenever there is affection of the ciliary body zone, sometimes it will lead to the shutdown of the ciliary body. And when there is a shutdown of the ciliary body, there will be no production or very less production of the aqueous. Whenever the production is less, the intraocular pressure will reduce. And the patient will complain of the visual loss. So why the patient complains of diminution of vision in the uveitis? So these are the features. Like proteins, cells are there in the AC. So cells and flare will be there. So they will hinder the normal movement of the lights from the eye, the normal transmission of the light from the anterior segment. And the patient will complain of the diminution of vision, raised intraocular pressure. Raised intraocular pressure will lead to the development of the corneal edema also, which will enter cyclitic membrane. As I have mentioned, the cyclitic membrane stops the going the light from the anterior segment to the posterior segment, and when the light does not perceive at the optic macula, the vision deteriorates. Presence of the vitreous exudates. In the vitreous cavity, when there are opacities, the light won't be able to cross the vitreous cavity properly. Macular edema, papillitis. And the last is phthisis bulbi, where the patient will be blind. Total loss of the vision will be there in that condition. So these are the few conditions which will lead to the affection or development of the uveitis in patient. They are not the particular solitary involvement of the eye. These are the particular syndromes, conditions which will lead to the affection. And along with that, they lead to the development or affection of the eye in the form of development of uveitis. So, the thing is that is ankylosing spondylitis. It's affected mainly the sacroiliac joint and the axial system of the human being, more towards the found in the males. And over the time, patient will start developing the bony deformities. Patient will have difficulty in the movement, in the flexing the sacroiliac joints or other joints of the body. And on examination, when we'll see these are the patients with the ankylosing spondylitis are actually B27 positive. It's a marker for diagnosing the disease, but this is not present only in this condition. We will discuss over the slides, like what are the conditions are present with the HLA-27 positive markers. And the affection in the eye will be, the patient will present with the development of recurrent anterior uveitis. He will have the recurrent episodes of uveitis over the time, and the patient will keep on coming. You have to keep under the patient under observation along with the other management which will be going on for the patients. And their management is also a bit different from the normal anterior uveitis or normal uveitis which you will do the management in the normal patient. They can need some other kinds of medications or some other drugs also to get managed, because the recurrent uveitis, you can't continue the same treatment every time to the patient. And maybe those drugs sometimes is not effective over the patient. So in that conditions, we have to change the medication, and we have to keep that for the another drugs are available, drugs which can be used for, which are made for the particular uses of the particular conditions, which can affect, which can manage along with uveitis the other features also, other deformities or other illnesses which the patient has in their body problems and all. So we will prefer to give those kind of medications, so the patient will have better compliance and improvement better single medication. So I have mentioned you, these are the symptoms which were present in the coming to the uveitis features in the ankylosing spondylitis. The uveitis features will be almost same. It's not the uveitis has certain particular differences. Uveitis will be the same as we have discussed the uveitis feature. The uveitis is same. The only thing, the pathophysiology or underlying etiology will be different, so which we have to take in the consideration while we are managing these kind of illnesses. And there is few heterochromatic iridocyclitis or cyclitis. I have already mentioned the name of this, where I was mentioning the fine stellate kind of KPs. We will see in the this. So this is an enigmatic disorder. The etiology of this, which is not known actually. Usually the patient will be young adult, more in the females, and it will be usually it affects unilateral. And patient will have the features of uveitis when it will present to you, and it's quite painless. So patient won't be coming to hospital regularly, and it will be professional finding. So you will find this condition sometimes when patient will come for the cataract surgeries. Okay, so the classical feature, this is quite unilateral. The patient will have the heterochromic iris, and it's progressive, painless, and chronic uveitis. No synechial formation. Patient will usually present once the cataract has come, and with the diminution of vision can lead to the development of glaucoma. And this disease usually is the chronic, but not that severe, and has a good prognosis over the time. We can admit the patient, we can explain the patient what is there, and based on that, the patient will be treated and manage the patient accordingly. Yeah. And the thing is, in this, usually the synechial heterochromic iridocyclitis does not have the synechial. So pupillary dilatation will be normal, and the patient will not have any raised intraocular pressure, because there is no synechial formation. So the formation of the seclusal pupillae or occlusal pupillae or these kind of information, they won't be there in the posterior chamber formation. So the aqueous hindrance or formation of anterior synechial. So neither formation nor the drainage of the aqueous humor will be affected. So the anterior chamber pressure will be normal, cornea will be normal, the patient will be quite normal, rather than finding of the, sometimes the patient will be presenting to you with the cataract, and only the finding will be like young adult, unilateral, and fine stellate KPs will be there, which on the basis of that, which you can make the diagnosis of heterochromic iritis. Yeah, but whenever this kind of patients come to you, make sure that rule out if there is involvement of the posterior segment also. Just does not just old chronic uveitis with fine KPs and no other specific features of the active uveitis or anterior uveitis does not mean that it can't affect the posterior segment. It can lead to the affection of the posterior segment also. So if you are taking for the cataract, explain the patient, assess the posterior segment if it is visible. See if there is another pathology, any other pathology there in the posterior segment, either in the vitreous, retina, in the choroid, whatever you can make. And based on that, explain the prognosis to the patient. But usually the patients have good prognosis in that. Even after the cataract, patient will have the good vision prognosis. And the connective tissue disorder is the sarcoid. The sarcoid is a connective tissue disorder. Okay. Will lead to the involvement of multiple structures like the lungs, the skin, joints. All these things will be affected in the body. And along with that, it can lead to the affection of the eyes also. So, as it's mentioned, multi-system disorder. On the skin, it will lead to the multiple granulomatous painful lesion formation. This is quite tender erythematous lesion, like erythema, they are known as erythema nodosum. The patient will have the hilar lymphadenopathy, which is quite significant and will be seen in the more than 90% of the cases, or almost in the 90% cases. That's why exercise is quite important feature, which we should get it done in the patients when we suspect the sarcoid or multisystem disorders. There will be fibrosis, exudates, and parenchymal infiltrates in the lungs, along with the hilar lymphadenopathy. Patient will have the fewer mood joint problems also, and the classical features, the patient with sarcoid had hypercalcemia on the examination and elevated serum angiotensin converting enzyme. The ECE levels will be significantly markedly elevated in the sarcoidosis. So whenever the patients, any patient with multi-system disorders like joint problems and uveitic features, will suspect the ankylosing disorders, letters with sarcoid also. But if the patient gives the history of any breathing problem, lung involvement, with dermatological involvement, we suspect the sarcoid, and in that we should get checked then the patient blood calcium level and the serum ACE levels. They are quietly raised, and the sarcoid can affect as the other diseases, anterior, posterior, or the intermediate level. So it can lead to the any kind of uveitis, including the pan uveitis. So another class, toxoplasma chorioretinitis. You know, the toxoplasma is a protozoan. The positive agent is toxoplasma gondii, which causes the toxoplasmosis in the human. You know, everyone has read the microbiology. It occurs for an infection reach to the human body by eating the undercooked or meat or any food which is uh, infected with the pets, like cats. Cat is one of the important source for the occurrence of these infections, which is common in the pet populations where the also, cats are there. So can be transmitted across the placenta to fetus also, and can lead to congenital toxoplasmosis. So it's better to be take care of that. And the cat is the primary host, and humans and other animals are the secondary hosts. So how the patient will present? The normal uveitis features which we have mentioned, if you affect the anterior, uveitis can be affected, and it can lead to the clinical features like the development of the inflammation in the vitreous or other chorioretinal features that lead to the chorioretinitis also. And based on that, once we'll make the diagnosis, if any picture is there, I'll show you in the few upcoming slides how the chorioretinitis, if it is there, or then how to manage the particular condition. Uveitis part management is okay, but based on the etiology, if it is connective tissue or infection, we have to mention that the patient will be treated with pyrimethamine and sulfagine, clindamycin, oral corticosteroid and topical corticosteroid, along with cycloplegics to relieve the cyclospasm on the main medications. Yeah, see the pictures. You can see the hazy media. That is because of vitreous seeding. The vitreous has been infiltrated with the toxoplasma exudates, and you can see the chorioretinitis lesion. These are the toxoplasma chorioretinitis lesion, which will be seen in the toxoplasma. you can understand. They're explaining these things in the short, so we can finish the topics in the time. Coming to the Beckett's disease. What is Beckett's disease? It's an autoimmune disease. Okay. So it is usually found in the Mediterranean areas, and the clinical features are the will. This is not only the condition which affects the eye, it affects the development of the joints, it affects the joints, mouth, and several parts of the body. So the main features which patient will be presenting with urogenital ulcers. Patient will have the pan-uveitis features with vasculitis sometimes, anterior uveitis with hypopyon and arthritis. Patients will have to be treated with immunosuppression, but still the patient with Beckett disease usually have the poor prognosis. Sympathetic ophthalmia. This is a rare disorder in which it occurs when there is a penetrating, usually the penetrating ocular trauma to one eye, then it will lead to the development of granulomatous uveitis in the other eye. And that condition is known as the sympathetic ophthalmitis or sympathetic ophthalmia. It's a classic autoimmune disorder. It can usually it doesn't occur simultaneously. It can occur from any time after the knee surgery. Usually it occurs from 10 days to 6 months after the injury to the one eye. It's managed with the immunosuppression as well as the steroids. So, coming to the uveitis in children, like all the features which we have mentioned can develop uveitis in children also, but there are particular few conditions which can cause uveitis in children in the condition. For example, toxocariasis. Toxocariasis is caused by Toxocara canis, which are helminth. It occurs from contact with the dog feces. As I mentioned, the Toxoplasma gondii usually occurs with the cat feces. This occurs usually with the dog feces. And it can lead to the pan-uveitis in children, usually uniocular. The other condition which can affect the uveitis in the patient are the juvenile idiopathic arthritis associated with uveitis. So, this is a type of seronegative arthritis, but for rheumatoid arthritis is seronegative. This RF factor will be negative, but usually the anti-neutrophilic antiplasmic antibody will be positive. The patient will have the deformed joints, will be asymptomatic till the late uveitis features also have developed, and the patient will have the poor prognosis and can have the development of band keratopathy, increased ocular pressure, cataract, and the other few important causes toxoplasmosis, as I have mentioned previously also, can cause, and the idiopathic intermediate uveitis. So these are the questions which we have read till now. Now we'll move further on the investigation and the management part of uveitis. So we'll go for the quick revision what we have studied till now. This will help in assessing the proper understanding etiology and everything. So start from the first slide, that is uveitis. Now you all of know what is uveitis. It's nothing but the inflammation of the uveal tract of the human body. As you can see the normal eye. This the uveal structure which has the ciliary body, iris, and the choroid. The inflammation of this is uveitis. And separately, so this is the definition of uveal tract of inflammation of uveal tract and adjacent structure. And the uveal tract consists of iris, ciliary body, and the choroid. Based on the location of inflammation, it's anterior, which is iridocyclitis, intermediate uveitis, that is cyclitis, and posterior uveitis, where the retinitis, choroiditis, choroidoperitis, and involvement all the structure is the pan-uveitis. This is the diagram which shows the etiology, as I mentioned, autoimmune infections like Toxoplasma, Toxocara, neoplastic aspirate syndrome, trauma, post-operative, The quite common features of the anterior uveitis are the pain, redness, loss of function, swelling, exudates, and the exudates deposits at the various places. So this is the normal picture of aqueous flow which I have mentioned, and how does it get affected in the uveitis patient, and how does the patient will develop the development of the increased intraocular pressure and other features. So based on that, you can assess. So these are the proper findings of those. These are exudates get deposits at the various levels. So this is the first deposition at the, which I have mentioned, but the sequence wise, the anterior most structure where they will get deposit the cornea known as keratic precipitate. What are the types of keratic precipitates based on their deposition and all things we have already discussed. They are button fat, small, stellate shaped, old. These are the cataracts with the keratic precipitates. Sorry, these are keratic precipitates on the slit lamp examination. And anterior chamber reaction which will happen in the anterior uveitis features. So what is the flare cells? I have already explained this picture. This shows the Brownian movement of the cells along with the flare. So what is the grading of the flare? I have mentioned 0, +1, +2, +3, +4 the same way. What is the grading for the cells? I have already mentioned the +1, +2, +3, +4. So these cells and flare, they will help us in assessing the severeness of the uveitis, and the management will be depends over the just of the features. Hypopion, as I mentioned, the collection of pus in the anterior chamber, how the pus get forms in the anterior chamber. That is nothing but the excessive production of exudates. When exudates are too high, they'll get clumped and get deposited in the anterior chamber. So that is exudates form. Pus collection in the anterior chamber is hypopion. This is another picture for the hypopion. Iris, I have mentioned what all the things will be there on the iris. Muddy iris nodules. So this is the nodular iris, which shows the various nodules which are get deposited over the iris, either pupillary margin or over the stromal layer of the iris. And the picture which shows the atrophy of the iris. So picture is this is the I have mentioned the neovascularization of iris. So this is the rubeosis. Neovascularization. So these are the findings which will be there in the iris. In short, I think I have explained everything to you. And this is a pupillary finding, as I have mentioned, either the pupil will be totally constricted or there will be adhesion found, which is a posterior segment synechial formation, and the posterior synechial formation can lead to the development of irregular pupil, and the festool pupil. When we will dilate the pupil, we will see and hinder the tear product, aqueous production and aqueous drainage, and can lead to the intraocular pressure. This is the festool pupil after dilatation. You can see these are the various pictures of the festool pupil. And this is the seclusive pupilla and occlusive pupilla, which I have explained to you how the seclusive pupilla forms when there is a formation of 360-degree posterior synechial will hinder the coming of aqueous from posterior to anterior chamber, will lead to the bulging of iris, formation of iris bombay, forward pushing of iris lead to the formation of peripheral anterior synechial, lead to the formation which causes the anterior chamber to become funnel shaped and it leads to the increased intraocular pressure. Another thing is, so this is the place where you can see the anterior posterior synechial peripheral and lead to the formation of bulging of iris anterior synechial formation. This is the iris bombay. That's a picture of seclusive pupilla with proper funnel shaped anterior chamber or iris bombay formation. Funnel shaped AC. Occlusive pupilla, which cause the same condition, which almost similar condition, which will lead to the hindrance of the aqueous drainage from posterior to anterior chamber and will lead to the formation of anterior synechial as well as funnel shaped AC and development of the increased intraocular pressure. Another condition where you can see this is the occlusive pupilla. So coming to cataract formation, it's deposition of exudates over the lens. So deposition of Exudates over the lens will be breadcrumb appearance, posterior subcapsular polychromatic clusters, the pictures which I have shown to you. Like this is the PSC, yeah, where the posterior subcapsular deposit is there and the patient is not able to see the structures clearly or vision is hindered and patient will present to us. On examination, we'll get the PSC and we have to manage according to that. Nothing but the polychromatic cluster. There is a multi-chroma or polychromatic appearance of the lens with the formation of cataract and the patient has to be managed for that. This is the cyclitic membrane which is formed behind the posterior capsule. And we are managing this patient. And now that there is no cataract, but the vision hindering posterior capsule membrane is there. So we should remove this cyclitic membrane while managing these cases. And the involvement of posterior segment, if the exudates are in the posteriorly, they can lead to the movement of floaters. And that's how the floaters patient will complain. I have explained you. This is coming to the posterior segment affection where the involvement of retina as well as macula and disc has happened. So if there is a macular edema can lead to the diminution of vision. This is the picture which shows the involvement of the papilla and this is the severe papillitis. The disc architecture is lost. This is the term end stage of the severe of uveitis, where the patient has gone to the blind eye and the eye is going shrinkage, reducing in volume and weight and space, and the finally patient will lead into the shrunken eyeball. That is a simple line. This is the summary what the patient with the anterior uveitis will have the signs and symptoms. So the symptoms will be pain, redness, dimness of vision. The pain usually patient will give the complaint of pain in the morning time or evening. Signs will have congestion or deposition of exudates. The congestion can be either diffuse corneal congestion or circumcorneal congestion. And due to exudates, if the exudates are deposited over the cornea, patient will get the KPs, various types of KPs, which I have shown you. If the exudates are there in anterior chamber, you get the same cells, flare, and hypopyon. If exudates are there on the iris and pupil, we'll see in the next slide the iris. Patient will develop the nodules over the iris or sometimes neovascularization, or the iris is stuck with the exudates that will lead to those muddy iris. And the pupillary involvement, if there is a ring signing adhesion has formed and the total pupil is constricted. So if the adhesions are formed, there is the partial isolated synechiae are there, or there is a ring synechiae. The ring synechiae are there that can lead to the occlusal pupillae, blockage of aqueous in the posterior chamber, iris bombay formation, and lead to the increase in intraocular pressure, leading to formation of peripheral anterior synechiae. The same thing happens in the occlusal pupillae, lead to the formation of iris bombay and formation of peripheral anterior synechiae and glaucoma. And in case of incomplete synechiae formation, whenever people will be dilated, people will become totally irregular and festoon people. So these all things I have mentioned is just summary of what we are reading now. Yeah, with the exudates, if they reach to the posterior chamber, then what are the findings you will get? I mentioned here is the lens become cataractous. It shows the appearance of polychromatic luster or loss of luster with OPSC and breadcrumb appearance. Formation of cyclitic membrane can happen. In vitreous, you can get the cells and floaters. Macula can have the macular edema with diminution of vision. Optic disc papillitis can be there, which can lead to diminution of vision. And last stage is the patient has the complete blind eye, can go to the endothesis and develop the physical. Increased intraocular pressure, I have mentioned already that reduced intraocular pressure also can happen when there is affection of the ciliary body and the production is stopped. And causes of visual loss, I have mentioned from anterior to posterior segment, if there is a cornea, if there are corneal deposition of KPs on the cornea, or anterior chamber cells or flare, formation of PSC, cyclitic membrane, vitreous seeding, development of macular edema, papillitis, all these are the features which will lead to the development of occurrence of diminution of vision in the patient with the uveitis. So these are the few particular conditions which I mentioned in the patient, which can have, these are the particular conditions which have the other involvement of the disorder, either the connective tissue or autoimmune disorder or some other disorders. but they will lead to the development of eye also. Their management differs because we have to treat the underlying etiology of particular disorders in the way like patients should get benefited the whole as not only the uveitis part. So ankylosing spondylitis, as I mentioned, the sacroiliac joint is more affected, more common in the men, and it is usually HLA-B27 positive, and the patient will present with the recurrent anti-uveitis. Heterochromic iridocyclitis, cyclitis usually seen in young adult. It's usually unilateral. Patient will have painless chronic uveitis. So patient usually won't present to us with those patient, and with that patient can develop the development of the cataract, and patient will present to us with the cataract only. And usually the patient have good prognosis unless the posterior segment involvement has occurred, and patient can be managed quite easily with a good prognosis in that. Another thing, sarcoid, as I mentioned, the sarcoid multisystem disorder, which affects the skin, lungs, bones, and eye as well. So with this, whenever you suspect any patient has presented with erythematous lesions over the skin along with the respiratory problems, and you get the X-ray done, see there is a hilar lymphadenopathy or infiltrates in the lungs are seen, see get the all joints X-ray and rule out for any arthritis features. Examine for the eye for the uveitis feature, and if there are there, manage the patient with this. We suspect the sarcoidosis, kindly check the serum ACE level. This is quite significantly high in this patient, and it gives one indication towards the patient having the sarcoidosis. The toxoplasma mentioned by the protozoan Toxoplasma gondii reaches to the human with the undercooked or infected food with the cat feces. So the cat is the primary host, and the human and other organisms or other animals are the secondary host. Can lead to the usually involvement of the posterior segment, and the posterior uveitis is more common along with anterior uveitis. The management according to etiology will be managed with pyrimethamine and sulfadiazine, oral corticosteroid, and topical corticosteroid for the uveitis, and clindamycin. This is the typical features of the toxoplasma chorioretinitis. You can see the haziness of the fundus along with the chorioretinitic lesion. Beckett's disease and the multisystem disease. It's an autoimmune disease, usually present with the orogenital ulcers with the arthritis and panuveitis. And should be managed with the immunosuppressive agents along with the topical and oral steroids. The patient will usually have poor prognosis. Sympathetic ophthalmia. So I mentioned it's a occur usually in the traumatic conditions. Whenever there is a trauma to the one eye, and the other eye get affected over the time post injury anytime, usually from the 10 days to the 6 months. And it's a quite autoimmune disease, and the patient have diminution of vision or affection of the other eye over the time, and it should be managed with the systemic steroids and the immunosuppression. That's important in the management of sympathetic ophthalmitis. The patient after trauma should always be counseled and keep under observation for the occurrence of these features in the time. So these are the conditions. Uveitis in children. So usually the conditions which we have mentioned till now, other than uveitis in particular conditions, they also can affect the children. But there are particular conditions which affect the children more likely in the terms of development of uveitis. This patient will have these disorders, will develop with uveitis in early childhood. So one of them important is the toxocariasis. This is caused by Toxocara canis, and other than toxoplasma, it is in fact human get affected by either the feces infected with dogs or dog meat, and lead to the panuveitis. And usually is usually uniocular, and if this happens, you should manage it accordingly. And there is JRA, that is juvenile idiopathic arthritis, but this is seronegative for the rheumatoid arthritis. It's not seropositive. Usually it's seronegative for RA, but positive for the ANA antibodies. The patient will be presenting late. Even the screening is more important for the diagnosis because the patient will not develop the clinical signs and symptoms over the time so early, and the patient will be bending quite late with the infection in these conditions. And the prognosis of the patient with JRAs or children's usually are quite not good. Patient can develop the other deformities also, other deformities, only deformities along with that, the like pant-shaped keratopathy, cataract formation in the early age. And other than this, as we mentioned, the toxoplasma. The toxoplasma already I mentioned how it is get affected with the catfish. The same way it get affected, it can lead to the development of the uveitis in the children. Idiopathic intermediate uveitis. The idiopathic intermediate uveitis is the uveitis usually occurs in the children, like the cyclitis, but then it can progress to the anterior segment as well as the posterior segment also, and the child will have the anterior uveitis as well as the posterior uveitis along with this, and the child should be managed accordingly and should be ruled out for the other connective tissue disorders or any other disorders which are there to rule out. So even in the child, we should assess all these features which are there in the development portions, like signs, symptoms. The last revision, just briefing, is the signs and symptoms which you will see in any kind of prevention, irrespective of it's a like connected to disorder, multi-system disorder, or whichever. The same signs you will get, the same symptoms you will get. You have to examine the patient thoroughly, anterior segment as well as the posterior segment properly to make the diagnosis if there is any pathology, and then examine patient for the exudates there in the anterior and posterior segment. Then see about the intraocular pressure, see any findings if it is there, see what are the diagnosis you have made, and treat with the patient with the, if any there is a particular any etiology, helminth or protozoal infection. So treat with the patient with enteroprotozoal, anti-helminthic or any multi-system autoimmune disorder, then immunosuppressive, along with oral and topical corticosteroids with cycloplegics if needed for the pain removing. These are the same thing, Toxocara, Beckett's disease, which is autoimmune disease, so need to be managed with immunosuppression. And these are the children, which has causes of the uveitis in the children, should be managed accordingly. So, which are the autoimmune disorders usually should be treated with the immunosuppression along with the steroids, and the keep observation. Sympathetic ophthalmia patients should be keep counseled as well as should be kept under monitoring on the regular interval for occurrence of any features in the of the sympathetic ophthalmia, and if needed should be treated immediately on the urgent basis. That's it. So this is the introductory parts, and this is the introductory part: definition, clinical features, what is the etiology, different types of etiology, what will be the signs and symptoms in the anterior and posterior and the panuveitis. All things have been mentioned along with involvement of other multi-system or connective tissue disorder. So what are the findings or what are the systems will be involved in other these systems also have been explained to you, have been explained to everyone. So based on that, now the first part of our chapter, that is definition, diagnostic feature, sign, symptoms, etiology, assessment, making the diagnosis is over. Now in the next class onward, we'll discuss what are the investigations and what is the management part, and briefing about the management of the different conditions, like the different conditions where the patient has developed uveitis, like these particular conditions which we have discussed here just now, like Toxocara, helminth protozoal disorders and all these things. How this is to be managed, I have mentioned here also. So based on that, we should know the etiology and we should manage that. Autoimmune disorder should be managed with immunosuppression and with topical and oral steroids. some conditions will need in intravenous steroids also. So all these conditions, what are the medications to be given, and what are the frequency, how long should be given, how frequent the follow-up should be done, these all things should be mentioned with this, and patient should not suffer. So for the today class over, next class we'll discuss the investigation and management part of the uveitis.